Okay, this is the Farm Nutrition ATI Chapter 3, Nutrition Assessment and Data Collection. So nurses play a role in assessing the nutritional needs of clients. Nurses monitor and intervene with clients requiring acute and chronic nutritional care. Nurses should consider and incorporate the family's nutritional habits into a client's individual plan of care. Nurses should take an active role in assessing and teaching community groups regarding nutrition. A collaborative, interprofessional approach provides the best outcomes for a client. Providers and nurses collect physical assessment data, as well as serving as liaisons between the healthcare team and the dietitian. The Joint Commission, TJC, requires a nutrition screening within 24 hours of admission to an inpatient facility, with referral to a dietitian for clients at risk for malnutrition. Registered dietitians complete comprehensive nutritional assessments. Nurses monitor and evaluate interventions provided to clients. A client's physical appearance can be deceiving. A client who has a healthy weight and appearance can be malnourished. Cultural, social, and physical norms must be part of a client's assessment. Even with adequate client education, personal preferences can be an overriding factor to successful nutritional balance. Diet history. A diet history is an assessment of usual foods, fluids, and supplements. The diet history is a part of the nutrition screening performed using various settings to determine malnutrition issues. Components of the diet history include the following: time, type, and amount of food eaten for breakfast, lunch, dinner, and snacks. Time, type, and amount of fluids consumed throughout the day, including water, health drinks, coffee, tea, carbonated beverages, and beverages with caffeine. Type, amount, and frequency of special foods, celebration foods, and movie foods. Typical preparation of foods and fluids, coffee with sugar, fried foods. Number of meals eaten away from home, at work or school. Type of preferred or prescribed diet, ovo, lacto, vegetarian, 2 grams sodium, low-fat diet. Foods avoided due to allergy or preference, frequency and dose amount of medications or nutritional supplements taken daily, and satisfaction with diet over a specified time frame, last 3 months, 1 year. Tools to determine nutritional status. A physical assessment is performed by the provider or nurse to identify indicators of inadequate nutrition. However, other diseases or conditions can cause these clinical findings. Manifestations: hair that is dry or brittle, or skin that has dry patches, poor wound healing or sores, lack of subcutaneous fat or muscle wasting, irregular cardiovascular measurements, heart rate and rhythm, blood pressure, enlarged spleen or liver, general weakness or impaired coordination. Anthropometric tools. Weight. Weigh at a time of day wearing similar clothing to ensure accurate weight readings. Daily fluctuations generally are indicative of water weight changes. Percentage weight change calculation. Weight change over a specified time. Ideal body weight based on the HAMWI method, also called Rule of 6 for males and Rule of 5 for females, using height and weight calculation. Males is 48 kilograms or 106 pounds for the first 152 centimeters, which is 5 feet of height, and 2.7 kilograms or 6 pounds for each additional 2.5 centimeters, which is 1 inch. Females is 45 kilograms per 100 pounds for the first 152 centimeters, which is 5 feet of height, and 2.3 kilograms, which is 5 pounds for each additional 2.5 centimeters, which is 1 inch. During illness, weight loss is monitored to prevent or detect malnutrition. With starvation or chronic disease, weight loss indicating severe malnutrition greater than 5% a month, greater than 7.5% in 3 months, and greater than 10% in 6 months, greater than 20% in a year, with acute disease or injury, weight loss indicating severe malnutrition, greater than 2% a week, greater than 5% a month, and greater than 7.5% over 3 months. Height. Measure on a vertical, flat surface. Ask the client to remove shoes and head coverings and stand straight with heels together, looking straight ahead. Read the measurements to the nearest 0.1 centimeter or 1/8 of an inch. Obtain a recumbent measurement lying on a firm, flat surface for infants and young children. Body mass index, BMI. BMI measurements compare the weight to height to estimate the effect of the individual's body weight. Client factors should be considered when determining the value of BMI measurement. For example, a client who has large muscle mass compared to height can have an increased BMI, since weight can be influenced by both fat and muscle, or a client with normal BMI might have excess body fat. Healthy weight is indicated by a BMI of 18.5 to 24.9. Underweight is indicated by a BMI less than 18.5. Overweight is identified as an increased body weight in relation to height. It is indicated by a BMI of 25 to 29.9 and are about 20% above desirable levels. Obesity is indicated by a BMI greater or equal to 30. Clinical values: fluid I&O. Adults is 2,000 to 3,000 milliliters per day. Total average output is 1,750 to 3,000 milliliters per day. Protein levels are usually measured by albumin levels, although total protein is sometimes used. Many non-nutritional factors, injury, kidney disease, interfere with this measure for protein malnutrition. Expected reference range for albumin is 3.5 to 5 grams. Prealbumin, which is the thyroxine binding protein, is a sensitive measure used to assess critically ill patients who are at risk for malnutrition. This test reflects acute changes rather than gradual changes. However, it is more expensive and often unavailable. This is not part of routine assessment. Prealbumin levels can decrease with an inflammatory process, resulting in an inaccurate measurement. Prealbumin levels are used to measure effectiveness of total parenteral nutrition. Expected reference range is 15 to 36 milligrams. Less than 10.7 milligrams indicates severe nutritional deficiency. Nitrogen balance refers to the relationship between protein breakdown, which is catabolism, and the protein synthesis, which is anabolism. To measure nitrogen balance, record protein intake over 24 hours and divide by 6.25. A neutral nitrogen balance indicates an adequate nutritional intake. A positive nitrogen balance indicates protein synthesis is greater than protein breakdown, as during growth, pregnancy, or during recovery. A negative nitrogen balance indicates protein is used at a greater rate than it is synthesized, as in starvation, or a catabolic rate following injury or disease. Risk factors for inadequate nutrition. Biophysical factors: medical disease, conditions, hypertension, HIV, AIDS, preventative measures or disease treatments, including surgery or use of medications and supplements, genetic predisposition, which is lactose intolerance and osteoporosis, and age. Psychological factors is mental illness, which is clinical depression, excessive stress, negative self-concept, and use of comfort foods. Social determinants of health, neighborhood and built environment, pollutants in air, soil, water, cause of risks to food supply, limited options for food and community affect nutritious food choices, limited transportation methods affect ability to transport groceries. Social and community context is food preparation methods may increase likelihood of foodborne illnesses. Unstable living situation leads to inconsistent food supply. Health education materials may not include cultural food preferences. Economic stability may have to choose between quality foods and housing or educational expenses. Lack of health insurance impacts ability to consult with dietitian. Lack of affordable, nutritious food may lead to undernutrition or overnutrition. Food and nutrition, availability of food and nutrients. Access to healthy food options, reliable source of food. Health and health care. Lack of primary care resources limits follow-up for chronic conditions associated with obesity. Limited number of school nurses affect screening for nutritional deficits. Lack of access to telehealth resources for nutritional consults. Education. Literacy levels affect ability to read food labels. Education levels affect ability to earn wages consistent with cost of living. Education levels affect ability to problem solve and make healthy food choices. Effective risk factors on nutritional status. The following are examples of how risk factors can affect nutritional status. A client who has edema can require treatment with a diuretic and low sodium diet. Diuretics can cause sodium and potassium imbalances. A low sodium diet can be unappetizing and cause the client to eat less. Osteoporosis has many modifiable risk factors. A client who takes action to prevent osteoporosis, increasing intake of vitamin D and calcium, engaging in weight-bearing exercise, reducing use of alcohol, and tobacco products will positively affect their nutritional status. Poor self-concept can cause a client to avoid eating or to overeat. Nursing actions. In addition to determining the client's nutrient and calorie intake, assess other factors that might alter nutrient intake. Consult with the provider to see if the client's medical treatment plan needs to be altered to improve nutrition, such as administering a different medication to prevent the adverse effect of anorexia or adding a medication to treat nausea or improve appetite. Plan the client's schedule of activities to prevent interruptions during mealtime and to avoid fatigue, nausea, or pain before meals.